Hello and welcome to The Explainer. Today, we're diving into a topic that is, well, absolutely essential for every lactation professional's toolkit: the intersection of breast cancer and breastfeeding. Understanding this is so critical, not just for your practice, but for supporting clients through some of the toughest moments of their lives. So let's build that toolkit, and let's start with just how big this issue really is. To really get a sense of the scale of what we're talking about, let's just start with this number. Globally, 1 in 20 women will develop breast cancer in her lifetime. It's the most common cancer in women, period. And that means, as an IBCLC, you are absolutely going to encounter clients who are survivors, who are newly diagnosed, or who are just worried about their risk. So, we've structured today's explainer like a toolkit, moving through 5 key areas. First, we'll lay the foundation, the protective role of breastfeeding. Then, we'll get into a common clinical question: screening. From there, we'll tackle the acute challenge of a new diagnosis and the long-term goal of supporting survivors. And finally, we'll cover the absolute red lines, the critical contraindications you have to know. Okay, let's start with the most empowering part of our toolkit: the fact that breastfeeding itself can be a really powerful protective factor. This is that evidence-based link between lactation and a reduced risk of breast cancer, and honestly, it's a cornerstone of the counseling we do. Think about it. So many risk factors for breast cancer, like genetics, are completely out of a person's control. But lactation isn't. It really stands out as one of the few things a person can do, a choice they can make that can actively reduce their lifetime risk. That's a powerful message of agency that we get to share with our clients. And this isn't some tiny effect, it's actually dose-dependent. A huge meta-analysis back in 2015 found that breastfeeding for a cumulative total of more than 12 months was linked to a 26% reduced risk of breast cancer. And get this, an even bigger drop, 37% for ovarian cancer. So the longer the duration, the greater the protection. It's pretty incredible. All right, let's switch gears from prevention to a really common clinical question you're definitely going to face. A client who is lactating asks you, "Hey, is it safe for me to get my routine mammogram?" This is where we need to be super clear and confident in our guidance. This area is just filled with myths, so let's set the record straight. The Academy of Breastfeeding Medicine Protocol confirms that screening can and absolutely should continue during lactation. All the imaging types, mammograms, ultrasounds, even contrast MRIs, they're all safe for both the parent and the baby. The real challenge is just interpretation, because lactating breasts are denser. And that's why you might see ultrasound or 3D mammography being preferred. They just offer better sensitivity. Now, here is a simple tip that can make a huge difference for your client's peace of mind. To improve the quality and the accuracy of any breast imaging, just advise them to breastfeed or pump really thoroughly immediately before their appointment. What this does is it reduces the density of the breast tissue, making it way easier for the radiologist to spot anything unusual. It's such a small step, but it makes a really big difference. Okay, now we're moving into the most acute and challenging scenarios: what to do when there's a new diagnosis during pregnancy or postpartum. This is where the IBCLC becomes a truly vital member of a multidisciplinary care team, providing that specialized lactation support when a family needs it the most. Understanding the surgical options is so key to setting realistic expectations. With a total mastectomy, more than 95% of the milk-making tissue is gone, which means no lactation should be expected from that breast. With breast conservation therapy, or a lumpectomy, they preserve more breast tissue, but the combo of surgery and radiation usually means we should anticipate significantly reduced, if any, milk production on that side. Okay, these are some high-yield clinical pearls for your practice and definitely for your exams. First, preoperative weaning is not necessary. It might not even reduce the risk of complications. Second, and this is a huge relief for so many parents, the milk from a breast with cancer is not harmful to the baby. Third, if a sentinel lymph node biopsy is done with a radiotracer, there's usually a recommended 24-hour pause with pumping and discarding. And maybe most importantly, in many cases, the parent can continue to breastfeed from the unaffected breast. Now, active chemotherapy is a hard stop for breastfeeding, but the question that always comes up is, for how long? This table, it gives us a really solid data-driven framework for that conversation. Based on data from the Infant Risk Center, it shows the recommended waiting period after the final dose of some common chemo agents, all based on the drug's half-life. Of course, this decision is always made with the oncology team, but it gives everyone a framework for hope. So after navigating treatment, the next chapter often involves this really hopeful question from survivors. A client comes to you, they're pregnant now, and they want to know if they can breastfeed. Our role here is to provide really good anticipatory guidance and then close, supportive postpartum care. The very first point on this slide is probably the most important reassurance we can ever offer. Breastfeeding does not increase the risk of cancer recurrence, period. From there, we help manage expectations. The treated breast might not change much during pregnancy, and milk production will likely be reduced or totally absent. The untreated breast, though, can often produce a full milk supply, although sometimes prior chemo can reduce the overall capacity. So, for us as IBCLCs supporting a survivor, what does this all boil down to? It's really one primary responsibility: that baby's intake. We have to monitor infant weight gain very, very closely, supporting the parent's feeding goals while making absolutely sure the baby is thriving. This often means having a plan for supplementation if it's needed, all while maximizing the parent's own milk production. And finally, we have to be crystal clear on the non-negotiables. These are the red lines, the absolute contraindications where the risk to the infant simply outweighs the benefits of breastfeeding. First and foremost, breastfeeding is absolutely contraindicated during active chemotherapy. These are powerful drugs that can pass into breast milk and are potentially toxic to the infant. They can cause serious issues like neutropenia, which is a dangerous drop in the baby's white blood cells. There is zero ambiguity here. It's a hard no. Second, aromatase inhibitors. This is a common form of long-term endocrine therapy for hormone receptor-positive cancers. These medications are also contraindicated because they can mess with estrogen metabolism in the infant. So breastfeeding is just not considered safe while a patient is taking them. And third, targeted therapies like trastuzumab, which you might know as Herceptin. Now, these are large molecule drugs, and they probably don't transfer well into milk. But the thing is, there are simply no data to confirm their safety during lactation. And when there's no safety data, the recommendation is clear: do not breastfeed. And let's end with a look to the future, which is pretty fascinating. Researchers are now proposing the creation of breast milk repositories using samples from women with breast cancer. By studying these samples, they hope to identify biomarkers that are shed into the milk. And this just leads to this amazing question. Could a person's own milk one day become a tool for understanding, predicting, or even monitoring their cancer risk? It's a pretty wild thought that just shows how much we still have to learn.
We've got 10 IBCLC exam-style case questions pulled straight from clinical protocols from the research. Yeah, think of it like this. We give you a scenario, 4 possible answers, and we'll together sort of break down the correct one. We'll explain why it matters, what the key takeaway is, all based on the source material.
Exactly, like a high-stakes knowledge game for your brain. Okay, let's unpack this. Let's dive in. All right, first up, we really need to nail down the definition. This is fundamental.
Defining PEFE and its impact.
Okay, scenario 1. A lactation consultant is looking at a patient's chart, sees pregnancy-associated breast cancer, PBC. Based on the latest definitions, the research, what's the most accurate way to understand PBC and its typical prognosis?
Okay, your choices are: A, PBC is only diagnosed during pregnancy and usually has a better prognosis because it's caught early. B, PBC includes diagnoses during pregnancy, lactation, or within 1 year postpartum, and it's increasingly seen as more virulent with a poorer prognosis. C, PBC is any breast cancer diagnosed within 5 years of childbirth, usually estrogen receptor positive. D, PDC is only diagnosed postpartum, and its prognosis is pretty similar to non-pregnancy associated breast cancer.
Okay, so getting this definition right is key. Which one is it?
The correct answer here is B. PABC, the accepted definition now, covers diagnosis during gestation, so pregnancy, or during lactation, or within that first year after birth.
Right.
And the really critical piece, the insight, is that postpartum breast cancer, specifically that window, it seems to be often more aggressive. It's linked to a poorer prognosis compared to cancers diagnosed at other times.
Wow, okay. So not just during pregnancy and actually more aggressive, potentially. That feels counterintuitive somehow. So why? Why might it be more virulent, and what makes diagnosis tricky here?
Yeah, it's a really important question. There are a few things going on. The normal physiological changes in the breast during pregnancy and lactation: increased density, blood flow, lumpiness. They can mask tumors, make them harder to feel or see on imaging initially.
Okay, so detection is harder.
Exactly. And Diagnosis often gets delayed because, understandably, a lump might be dismissed as, a clogged duct or mastitis, something related to breastfeeding. That delay means the cancer might be more advanced when it is found. Right.
Plus, PABC is often estrogen receptor negative, which can mean it's inherently more aggressive and less responsive to some hormone-based treatments.
Makes sense. Okay, let's move to the second scenario. This one's about prevention, something many new moms wonder about.
Breastfeeding's protective power.
All right, a new mother. She's worried about her family history of breast cancer. She asks her IBCLC, that's the lactation consultant, if breastfeeding gives her any protection. Based on current evidence, what should the IBCLC tell her about breastfeeding and breast cancer risk?
Okay, the options. A, breastfeeding definitely prevents all types of breast cancer, doesn't matter how long you do it. B, some older studies showed protection, but recent big studies haven't found a significant link between how long you breastfeed and your risk. C, breastfeeding for longer periods, especially over 12 months, is consistently linked to a reduced risk of breast and ovarian cancer, partly by reducing ovulations and lowering estrogen. Breastfeeding only protects women who carry the BRCA gene mutations. This comes up a lot, I imagine. People wanting to know what they can actively do. What's the evidence say?
The best answer is C. Breastfeeding is actually seen as one of the key modifiable factors for prevention, things you can actually influence.
That's powerful.
Yeah. And large meta-analyses looking at lots of studies together consistently show that longer breastfeeding, especially hitting that 12-month mark or beyond, is linked to a significant drop in risk for both breast and, interestingly, ovarian cancer too.
Okay, so it's not just a maybe, it's a consistent finding. And you mentioned mechanisms, lower estrogen, fewer ovulations.
Exactly. During lactation, ovulation is often suppressed, especially with exclusive breastfeeding early on. Fewer lifetime ovulations means less cumulative estrogen exposure for the breast tissue. There's also a theory about cell differentiation. Breastfeeding might help mature breast cells in a way that makes them less susceptible to becoming cancerous, maybe clearing out potential carcinogens too.
So even though maybe not every single study finds a huge effect, the overall weight of evidence is pretty strong for protection.
That's right. The overall body of evidence, especially from large reviews, points strongly toward the protective effect for most women, particularly with longer durations.
Good to know. Okay, scenario 3. This one deals with a really tough situation, needing treatment during pregnancy or postpartum.
Chemotherapy and breastfeeding during and after pregnancy.
So a patient is diagnosed with breast cancer while pregnant. She's going to need chemotherapy. She wants to know if she can breastfeed her baby after delivery. What's the most appropriate advice here?
All right, the choices. A, she can breastfeed right through chemo. The drugs don't really get into the milk much. B, she should breastfeed right after birth, but breastfeeding is contraindicated during chemo. She can pump to keep her supply up, though. C, breastfeeding's only off limits during the first trimester of chemo. After that, it's safe. D, she needs to wean the baby abruptly, avoid any drug transfer, and pumping isn't recommended either.
This must be incredibly difficult for mothers. What's the safest, most accurate guidance?
The correct answer is B. Typically, chemotherapy is actually paused, usually about 3 to 4 weeks before the due date.
Oh, okay.
Yeah, specifically to allow the mother's body to recover, her blood counts to normalize, and to make immediate postpartum breastfeeding possible and safe right after delivery.
So there's a window there.
There is. But, and this is critical, breastfeeding is absolutely contraindicated while actively receiving chemotherapy. These drugs are powerful antimetabolites designed to kill rapidly dividing cells. They do cross into breast milk.
In significant amounts.
Yes, in amounts that could be toxic to the infant. It's just not safe.
That's tough. So what about maintaining supply? Pumping.
Yes, pumping is possible.
Yeah.
A mother can pump during her chemo cycles to help maintain milk production. But, and this is vital, all the milk expressed during chemo and for a specific period afterwards must be discarded. Pump and dump, as they say. It preserves the possibility of resuming breastfeeding later, once the drugs have cleared her system. But it's a lot of work and emotionally taxing. Also, if stopping lactation becomes necessary because of the treatment plan, gradual weaning is always better than abrupt weaning to avoid complications like engorgement or mastitis for the mother.
That makes sense. And the emotional support aspect must be huge here.
Absolutely essential. Dealing with undesired weaning on top of a cancer diagnosis requires a lot of support from the healthcare team.
Okay. We've touched on PBC itself and some treatment realities, but Before treatment, obviously, comes diagnosis. Let's shift gears now to how doctors figure things out, especially when lactation adds layers of complexity.
Diagnosing lumps in lactating breasts.
Scenario 4. A breastfeeding mother finds a lump. It's persistent, doesn't go away after, say, 72 hours of the usual tricks for plugged ducts, heat, massage, frequent feeding. What's the most critical next step for her doctor or provider?
The choices are A, reassure her it's probably just a normal, lumpy, lactating breast. Tell her to keep doing self-care. B, immediately tell her to wean the baby so they can get clearer imaging and do a biopsy. C, recommend medical evaluation, including imaging. Persistent lumps need investigating for potential malignancy. D, just prescribe antibiotics for possible mastitis without looking further.
I bet this happens quite a bit. A persistent lump during breastfeeding. What's the right move?
The correct answer, and the critical one, is C, medical evaluation, including imaging. While yes, lactating breasts are often lumpy and change a lot, any lump that sticks around for more than 72 hours despite appropriate self-care measures must be investigated.
Why the 72-hour mark specifically?
It's a reasonable time frame. Most benign lactation-related issues, like a stubborn plugged duct or early mastitis, should start to show improvement within that window with proper management. If it's not changing or getting worse, you can't assume it's benign anymore.
And diagnosis is harder during lactation, right? You mentioned that earlier.
Exactly. The increased density, the vascularity, the sheer volume changes it makes feeling for lumps accurately harder, and standard mammograms can be less sensitive. Images might be harder to interpret. That's why you can't just reassure. You need to actively rule out malignancy with proper clinical assessment and imaging. Assuming it's just lactation can lead to dangerous delays.
Which leads us perfectly into the next question, number 5, about the imaging itself. What's safe?
Radiologic studies safety during lactation.
Okay, so a lactating woman needs breast imaging for a suspicious lump. She's worried, understandably, about safety while breastfeeding. Which imaging types are generally considered safe, and what kind of prep is recommended?
Here are the options. A, mammograms and ultrasound are okay, but contrast MRI is a no-go because of the gadolinium contrast agent. B, all common types, mammogram, ultrasound, and contrast-enhanced MRI are safe during lactation. Expressing milk before the exam is a good idea. C, only ultrasound is truly safe. Mammograms and MRI mean you have to stop breastfeeding temporarily. D, none of them are safe during lactation. Breastfeeding has to stop completely until everything's figured out.
Okay, this is where some myths might come in, right? What's the actual recommendation?
The correct answer is B. And this is really important information to get out there. All the standard breast imaging tools, mammography, including the 3D kind called tomosynthesis, breast ultrasound, and even contrast-enhanced breast MRI, are considered safe during lactation.
Even the MRI with contrast, I think that surprises people.
It does. The concern is about the gadolinium contrast agent used in MRI. Yes, a tiny, tiny amount does get into the breast milk. And the amount absorbed by the infant through the milk is considered negligible, clinically insignificant. Leading authorities say there's no need to interrupt breastfeeding because of it.
Wow. That's huge news for mothers facing this. Debunks a major worry. Is there anything they can do to help the imaging quality? You mentioned expressing milk.
Yes, absolutely. Breastfeeding or pumping right before any breast imaging exam is recommended. Why? It empties the breast, reduces the density and the amount of milk, which makes the images clearer and easier to interpret, especially helpful for mammograms.
And ultrasound is particularly useful here.
Often, yes. Ultrasound doesn't use radiation, and it's very good at evaluating masses in dense breast tissue, which is common during lactation. It often provides the highest sensitivity in this population.
Okay, great clarification. Let's move to scenario 6. After imaging finds something suspicious, the next step is often a biopsy.
Image-guided core needle biopsy, CNB considerations.
So a breastfeeding patient needs an image-guided core needle biopsy, a CNB, of a breast mass. What are the key things for her lactation consultant or care team to discuss with her about this procedure?
Your choices. A, CNB means you have to completely wean before the procedure. It's too risky otherwise. B, it's safe and effective, but there's a slightly higher risk of bleeding and infection in lactating breasts. Emptying the breast first and using strict sterile technique helps minimize this. C, CNB isn't as accurate as surgery for lactating breasts and often causes milk fistulas, leaks. D, you have to permanently stop breastfeeding from that breast right after the biopsy.
Okay, the biopsy. This is often the definitive diagnostic step. What's the guidance for doing it while breastfeeding?
The correct answer is B. Core needle biopsy remains the standard, the preferred method, even during lactation. It's accurate, it's much less invasive than a surgical biopsy, avoids general anesthesia, quicker recovery. Lots of advantages.
But there are some specific considerations for lactation, the increased risks mentioned in B.
Yes, slightly increased risks. Because the lactating breast is highly vascular, lots of blood flow, there's a bit more risk of bleeding or hematoma formation. And because there are active milk ducts, there's a small risk of infection or developing a milk fistula, which is basically milk leaking through the biopsy tract.
Okay, slightly higher risk, but manageable. How do you minimize those risks?
Exactly. They are manageable and minimized with specific steps. First, have the mother empty the breast, thoroughly feed the baby or pump right before the procedure. That reduces milk pressure and engorgement. Second, the person doing the biopsy needs to be meticulous about hemostasis, controlling any bleeding. And third, strict aseptic sterile technique is crucial to prevent infection.
And what about breastfeeding afterwards? Does it need to stop?
No, not permanently. Usually breastfeeding can resume from the affected breast, often within 12 hours or so, maybe after applying pressure for a bit. Continuing breastfeeding can actually help prevent milk stasis, which could worsen things. So stopping isn't typically necessary or recommended long-term just because of the biopsy.
All right, we've walked through diagnosis. Now, let's say a diagnosis is made. The focus shifts to treatment, bringing a whole new set of questions about lactation. Let's start with the impact of surgery.
Breast surgery and lactation capacity.
Okay, scenario 7. An IBCLC is counseling a woman. She had breast cancer previously, underwent surgery and radiation. Now she's pregnant again and wants to breastfeed. What's the expected impact on her ability to produce milk from the treated breast?
The choices are A. Both total mastectomy and breast conservation therapy usually allow for normal milk production from the affected side. B. After a total mastectomy, you shouldn't expect adequate milk production from that side. After breast conservation therapy, significantly reduced milk production is likely. C. Total mastectomy actually preserves milk tissue, so lactation's fine, but radiation always stops milk production completely. D. Being able to lactate from the treated breast after surgery and radiation is really unpredictable and pretty rare.
This gets to the long-term consequences of treatment, doesn't it? What can women realistically expect?
The most accurate answer is B. It really depends on the type of surgery and treatment. With a total mastectomy, the entire breast gland, including the nipple and areola, is typically removed. There's just no functional tissue left to produce milk adequately on that side.
Okay, so mastectomy side is generally out for milk production. What about breast conservation lumpectomy plus radiation?
Right. For breast conservation therapy, or BCT, it's different. A lumpectomy removes the tumor plus some surrounding tissue, so some milk-producing parenchyma remains. However, milk production is very likely to be significantly reduced on that side.
Why the reduction? Is it just the tissue removed, or does radiation play a role too?
It's both. The surgery itself removes some glandular tissue and can potentially damage nerves involved in the milk ejection reflex, the letdown. But radiation has a major impact. It causes irreversible fibrosis, basically scar tissue formation throughout the remaining breast tissue.
Scarring.
Yes, and that scarring prevents the normal changes needed for lactation. The ducts can't proliferate and expand properly to carry milk. The tissue just doesn't respond the same way.
But there's some good news, right? Can the other breast compensate?
Absolutely. That's the crucial point. A single unaffected breast can often produce a full milk supply, enough for the baby to grow well. So exclusive breastfeeding might still be possible just using the untreated breast. Close monitoring of the baby's weight gain is key, of course.
Okay, let's look at question 8, focusing on other specific treatments.
Sentinel lymph node biopsy and radiation therapy and lactation.
Scenario. A breastfeeding mother with breast cancer is going to have a sentinel lymph node biopsy using radiotracers. That's followed by radiation therapy to the breast. What are the key breastfeeding considerations for these specific procedures?
Your choices. A. Breastfeeding has to stop permanently before the biopsy and shouldn't resume during radiation. B. No interruptions needed for the biopsy, and breastfeeding during radiation is actually encouraged to soothe the breast. C. The sentinel node biopsy with radiotracers might mean a 24-hour break from breastfeeding, discarding milk, and breastfeeding during radiation might worsen skin reactions. D. Milk expressed after the biopsy is safe to feed immediately, and radiation doesn't affect the skin for breastfeeding.
Okay, 2 different things here. The radioactive tracer for the lymph node check and then the radiation treatment itself. How does breastfeeding fit in?
The correct answer is C. Let's break it down. For the sentinel lymph node biopsy, if they use a radiotracer, a radioactive substance, to map the nodes, the standard recommendation is usually a temporary interruption of breastfeeding. typically around 24 hours. During that time, the mother should pump and discard her milk. This is because a small amount of radioactivity can be excreted into the milk, and her body itself is slightly radioactive for a short time. It's a precaution for the infant. Sometimes they use a blue dye instead, which has different considerations, but the question specifies radio tracers.
Okay, 24-hour pause for the tracer. What about during the weeks of radiation therapy?
During radiation therapy to the breast, it gets complicated. While the milk itself isn't radioactive from external beam radiation, continuing to breastfeed from the treated breast can worsen the expected skin side effects.
Like make the skin irritation or breakdown worse.
Exactly. Radiation causes skin reactions, redness, soreness, sometimes peeling or blistering. The friction and moisture from breastfeeding could potentially exacerbate that. So it becomes a discussion between the patient and her team, weighing the desire to continue breastfeeding from that side against the potential for increased skin toxicity and discomfort. Many women choose to breastfeed only from the untreated side during radiation.
Makes sense. Okay, number 9, moving on to adjuvant therapies treatments given after initial surgery radiation.
Adjuvant therapy is in breastfeeding.
All right, a postpartum patient with breast cancer is prescribed adjuvant therapy. This could be endocrine therapy like tamoxifen or an aromatase inhibitor, and maybe also anti-HER2 targeted therapy like trastuzumab. What's the most important guidance about breastfeeding for her?
The options are A, both endocrine therapy and anti-HER2 therapy are fine with breastfeeding, just need some monitoring. B, anti-HER2 therapy is generally safe, but endocrine therapy just needs a short break from breastfeeding. C, breastfeeding is not recommended during other anti-HER2 targeted therapy or endocrine therapy due to safety concerns for the baby and/or contraindications. D, these drugs only affect milk supply, not safety, so breastfeeding can continue if you supplement.
These are often longer-term treatments aimed at preventing recurrence. What's the word on breastfeeding with these?
The correct answer is C. This is a pretty clear-cut contraindication in most cases. Breastfeeding is generally not recommended while taking these adjuvant therapies.
Why not? Let's take endocrine therapy first.
Okay, for endocrine therapies, aromatase inhibitors are explicitly contraindicated. They work by drastically lowering estrogen, and the effects on a developing infant are unknown but potentially harmful. Tamoxifen safety is also largely unknown. While some older limited data exists, the potential risks of exposing the infant to a drug that manipulates hormones are generally considered too high. It's not recommended.
Okay, so endocrine therapy is generally out. What about the targeted anti-HER2 drugs?
Or anti-HER2 therapies like trastuzumab, Herceptin, or pertuzumab. These are large protein molecules, so maybe less likely to pass into milk in huge amounts compared to small molecule drugs. However, there's still a lack of robust safety data on infant exposure. And because these drugs target a growth factor receptor, HER2, there are theoretical concerns about potential effects on the infant. Plus, they are often given alongside or alternating with chemotherapy, which we already know is contraindicated. So the overall recommendation is not to breastfeed during anti-HER2 therapy.
So the bottom line is, for most standard adjuvant therapies, breastfeeding is not advised due to safety concerns.
That's generally the case, yes. And again, this underscores how crucial that multidisciplinary team approach is. Having open discussions involving a lactation expert, providing psychosocial support for potentially having to wean when the mother didn't want to, it's all incredibly important.
We have covered so much ground definitions, diagnosis, the impact of various treatments. Let's wrap up with one more specific, practical question, number 10, and then pull together the key takeaways. This question is about getting back to breastfeeding after chemo.
Resuming breastfeeding after chemotherapy.
Okay, final scenario. A mother finished a course of cyclophosphamide, a common chemo drug, for breast cancer after her baby was born. Her oncology team is advising her on when it's safe to start breastfeeding again after her very last dose. According to recommendations from the Infant Risk Center, a key resource here, what's the recommended minimum waiting period for cyclophosphamide?
Your choices are A, 7 to 10 days, B, 72 hours, C, 4 to 5 days, D, 24 hours.
This is super practical. When can she safely feed her baby again after this specific drug?
The correct answer, based on Infant Risk Center guidance often cited in protocols, is B, 72 hours. Cyclophosphamide has a known serum half-life, the time it takes for half the drug to leave the bloodstream, of about 7.5 hours. The general rule of thumb for many drugs is to wait about 5 half-lives for clearance, but given the nature of chemo, waiting around 10 half-lives is often advised for extra caution. For cyclophosphamide, that lands around the 72-hour mark.
So it's calculated based on how the body clears the specific drug. It's not just an arbitrary number.
Exactly. And it highlights that resources like the Infant Risk Center provide this kind of concrete, evidence-based information.
But you said minimum waiting period. Does it vary?
Absolutely. That's the crucial qualifier. These are minimums. The actual recommendation needs to be individualized. It depends on the specific dose she received, and her kidney and liver function, which affects drug clearance, maybe even the drug's metabolites. That's why the decision should always be made in consultation with the full oncology team, ideally including an oncology pharmacist who really understands pharmacokinetics.
Right. So use the guidelines as a starting point, but personalize the advice.
Precisely. It empowers patients and clinicians to make informed choices together. And that really brings us to the bigger picture, doesn't it?
It does. You know, you've just navigated a really complex deep dive with us. We've unpacked the specifics of PBC, postpartum breast cancer. We've clarified the safety of diagnostic imaging, which was really eye-opening. And we've tackled the tough realities of treatment and its impact on lactation. By thinking through these clinical scenarios, these questions, you haven't just learned facts. Hopefully, you've gained a practical, actionable understanding. You're that much more well-informed.
Yeah, and it's fascinating, isn't it? We've talked about how breastfeeding can be protective for the mother against certain cancers. We know it's immense benefits for the child. Makes you wonder, given everything going on in breast milk, the antibodies, hormones, living cells, this incredibly dynamic biological fluid,
Right.
what else might we discover about its role? Not just as nutrition, but maybe as a system holding more keys to understanding disease, maybe even pathways related to cancer development or prevention in the future.
That is a fascinating thought. What more could this incredible biological system teach us? Something definitely to mull over until our next deep dive.